Those of you who don't know me, my name is Alejandra Méndez. I'm based in Santiago, Chile. I'm currently serving as a CCI Childhood Cancer International Vice President, and I'm also a board member of Fundación Nuestros Hijos, who work with underprivileged children diagnosed with cancer and their families. Since my experience with childhood cancer, I decided to devote myself to serve and make life easier for those families who are undergoing the cancer treatment of their child. So I'm currently involved in many local, regional, and international things, trying to make life and trying to improve quality of life and make the best quality of life and improve survival rates of those who are undergoing cancer treatment. So I don't know if there's enough. Should I pass the word to the others to introduce themselves, or what do you want, Kate?
Hang on. Can you hear me? There. No, are you happy to just start and then we'll introduce the rest when Jordana gets here? Is that all right? You're muted though. You're still muted.
Okay, do you want me to start with the presentation now? Or should we wait for the rest? I didn't get it. I start? Let me know if you want me to start now or if you want me to wait for the rest. Should I start?
Yes, please. Yes, please. Yes.
Okay. So today my goal is to highlight the importance of being sensitive when we talk about cancer and to reflect on the impact that language may have in childhood cancer patients and their families. I'm trying to move this. How can I just, okay, that's better.
Kate, just to let you know I'm in.
We will talk about war metaphors when talking about cancer. Years ago, I realized that there was something that really struck me when people use military language to talk about cancer. Being the mother of a childhood cancer patient, I heard this terminology extremely often. Something in my brain and heart was uncomfortable every time I heard them. Why did I feel so uncomfortable and uneasy? What effect was this language having in me? I started doing my own little research among the hundreds of families I work with, and I realized that I was not the only one. I've also met so many childhood cancer survivors in my journey and realized that for many of them, this was uncomfortable as well. According to experts, the use of language may have a big impact on people's views of a situation, any situation. Just to give you some context, until the mid-20th century, most patients diagnosed with cancer were almost given a death sentence. In 1971, President Nixon declared the war on cancer in the United States National Cancer Act. Humanity needed that after the devastation caused by cancer. But today, things have changed. We all know that in 2024, most cancers are curable. Therefore, it may be time to return cancer to its condition of being a disease and not a war, and to start treating cancer like any other disease. We don't describe other diseases such as heart disease, kidney disease, or diabetes using military language.
Jessie, if you would like to go to a little of the party, there is time.
Why would I go to the party? That party is for kids who beat cancer. I lost.
Cancer doesn't have winners and losers, and anyone who makes you feel that way does not know what they are talking about.
You made me feel that way. The stupid speech. I was 12 when I learned I had cancer. I was told I was in for the fight of my life. I battled each cell of my sarcoma. New Amsterdam taught me how to fight and how to win. Your party is called Fighting Cancer. So, yeah. Cancer won, and I lost.
Language always matters. When speaking about a disease, it matters a lot. And when speaking about a disease with child, it matters even more. It matters because it affects how children live with their illness and relate to those around them. As adults and professionals working with sick children, we have an obligation and an opportunity to choose language that is respectful, accurate, and empowering to our patients. All around the world, children love to dress and play like superheroes. All of us who are parents know how fun it is for them to wear a superhero cape and sword. Of course, sick children may enjoy this as well. When playing, children choose to be a ninja or a Superman. They are free to take this role and quit when needed. Children know that they are pretending and that the game will end when they decide to. What if the game doesn't come to an end? What if the kid feels he or she can't leave behind the superhero outfit? On the contrary, what if he is forced to wear it for a long, long time? So let's talk about how we use or people use the word cancer. We see that as a synonym of consumism, relativism, inflation, ignorance, indifference, and selfishness. What impact may this have in children or adolescents who are diagnosed with this disease? Let's go beyond that. I can even begin to count the number of obituaries that include the phrase, lost a battle with cancer, or other work terminology. Celebrities and non-celebrities, athletes, singers, TikTokers, parents, ninja warriors, and of course, children. Have we stopped to think the impact this language may have in patients and their families? What are we really communicating, even if we don't intend to do so? Jean Piaget's theory of cognitive development suggests that children may move through 4 different stages of learning. His theory focuses not only on understanding how children acquire knowledge, but also on understanding the nature of the intelligence. The concrete operational stage is the 3rd stage in this theory. This period begins around age 7 and continues until approximately age 11, and it's characterized by the development of logical thought. Before the age of 7, children can still rely heavily on concrete thinking. Child psychologists think that only at 11 is the beginning of abstract thinking, when children gradually develop the capacity to analyze, extrapolate, and develop the capacity to understanding metaphors and other kinds of figurative language. Children, especially young children, have a concrete way of thinking. It's also called literal thinking, because it's reasoning that focuses on immediate experiences and exact interpretations. Young children may have difficulties to understanding some forms of communications, such as humor, irony, idioms, and figurative language. As children mature, they begin to think symbolically and may be able to understand metaphors or symbols. Keeping in mind Piaget's stages of cognitive development, let's focus on what a child who's younger than 11 and diagnosed with cancer hears. I understand that all these expressions are used with the intention of supporting and motivating patients and their families, but this is not always the case. We adults understand the metaphor, but the patient may not. We, all the adults here, know that children who die from cancer have not died because they didn't try hard enough or because they didn't have the right attitude. Is that the message we're passing to them? The language we choose to talk with a child with cancer about the disease may have profound consequences. Is a warrior a positive figure? Does this help the kid? Patients may feel the burden of having to behave as superheroes who fight the disease. Superheroes are never afraid. They choose a cause to fight for. They are proud to defend this cause and will be happy to give their lives for it. They know what to do and won't hesitate to do it. They have special powers or weapons that make them unique. Are these the expectations we have from the children who are diagnosed with cancer? What do you see here? A kid who has cancer or a brave hero fighting against an enemy? Is something in the kid's body that needs removing? Is this a kid warrior in a war he or she may win or lose? What matters here is not what we, all the adults who have developed our capacity to understand metaphors, see or understand, but what the sick kid and his or her family understands. What is the message some patients may be getting? Cancer and its treatments can be grueling. Patients usually feel tiredness, fatigue, nausea, or other side effects that make day-to-day living difficult. But the social mandate received is, be a strong, brave, and resilient patient, and you will win this war. Don't you ever give up. Fight back. Be positive. Don't be a loser. This suggests that if you lack courage and strength, you may be beaten. When using war language, we are communicating that we exalt the values of optimism, courage, strength, stoicism, triumphalism, self-sufficiency. The children and adolescents with cancer I have met usually feel very differently. They feel angry, enraged, useless, terrified, sad, and vulnerable. Does this resonate to the survivors in this panel? It is okay to feel vulnerable, especially if you're undergoing an aggressive, long, painful treatment. The language may dehumanize the patient. When we use certain language, patients report that they feel these emotions are not allowed to be expressed. The use of words has the power to engage or include or to wall us from those with whom we most need to communicate. Sick children need to talk about their emotions, and adults should be aware of that. We must teach and encourage children to express their feelings and ask for help if they feel overwhelmed. Some patients are unable to open up as a result of the expectations they feel people have of them. This is important for their mental health after they finish treatment. Learning to cope and accept and express your emotions is probably the basis for a healthy adulthood. I understand that many children and their parents may feel inspired by the idea they are fighting for their lives. There are no right or wrong words for people talking about their own personal experience, and some may see their cancer experience as a fight or a battle. And if this is the case, patients and their families should proceed using the words that connect them with the goal of becoming healthy. And for them, this language is totally okay. But others find that the effort of keeping up a brave face might be exhausting. There's no such thing as a typical person with cancer, so people have different preferences when it comes to discussing it. For some young children, the message is clear. You need to fight like a warrior to win this battle. The use of certain language builds a reality. Fight cancer as a warrior builds the reality that there is something you can do to be cured of cancer. Depending on the developmental level, a child might think the cancer is their fault and the cure their responsibility, when in fact, we all know that if the child survives or dies, has nothing to do with his or her attitude or his or her willingness to survive. Aren't we putting the responsibility of the cure in the child? Is this what he or she may perceive? Why put this burden in the patient? If only the progression of cancer depends on being more or less positive, but it is not so. Attitude does not cure cancer. The progression of the disease depends on many other factors, such as the stage of the diagnosis or the effectiveness of the treatments. Despite this, many times patients and their families receive certain messages from their environment that, despite being very well-intentioned, end up being very difficult to manage emotionally in a society marked by the dictatorship of happiness. Developing a positive attitude can change the way you live your life, regardless of the challenges or adversities you face. Research by the American Cancer Society shows that a positive attitude in people with cancer helps reduce tension, anxiety, and tiredness, and lowers the risk of depression. It also may decrease distress, improving the psychological well-being of the patient. It also may provide better coping skills during difficult times, like managing side effects like pain, fatigue, nausea, or vomiting. A good attitude will definitely help us to deal better with the disease and to live our spirits. These advantages can be helpful for those undergoing cancer treatment, but will not cure a child with cancer. I'm sure everybody in this room have met extremely positive children who have died of cancer, despite their optimism and attitude. Studies have shown that keeping a positive attitude does not change a person's chance of survival or the course of their disease. A positive attitude certainly helps a lot, but cannot control cancer growth. Who is really fighting cancer? The sick child or the scientific team? The ones who are fighting cancer is the medical team. They need to defeat the disease and cure the child. They need to make the right decisions, choose the medications, decide the protocols or the procedures. Researchers need to figure out a way to solve this problem. When a patient dies from the illness, it doesn't mean he or she didn't fight a good fight. It means that in those cases, neither the drugs, nor the surgery, nor the other therapies could stop the malignancy's progression. If the child survives, the medical team succeeded. If the child dies, the medical team did not succeed, not the patient. The patient's job is to cope with secondary effects and emotions and wait to be cured. Have you heard this for the survivors in the group? There are many worse things out there. There are people who are worse off. This is a comment that tries to downplay the situation to avoid stress. But what it does, it makes the child feel guilty for having emotions they believe they shouldn't feel. This comment neither reduces the pain nor provides a solution. You must have the best attitude. You can't avoid having thoughts and emotions that you experience. This is something beyond our control. This type of comment creates greater insecurity by making the child think their attitude could worsen the illness. If you're sad, your family will be sad too. The illness generates emotions in everyone, including the child. No one is to be blamed for that. It's impossible to always be strong. Therefore, if you have to be sad, it's better not to be alone. Instead, lean on your family by sharing your feelings. Let's talk about this toxic positivity. With the best intention, I know it's the best intention, we try to downplay the illness with phrases like cheer up or you have to be strong. Attitude is important. Initially, the patient may not feel overwhelmed by these remarks, but reconsider them when receiving certain messages from the environment. Sometimes these phrases achieve the opposite effect, that the child feels guilty for the normal feelings that overwhelm them during the treatment, and for not being able to be happy and optimistic all the time. So, what are the consequences? When the need for emotional release is blocked, suffering increases. It generates lacks of control, helplessness, and insecurity. I don't know what will happen if I can be more positive. Self-esteem problems. I'm not up to the situation. I should be better. I may disappoint them. Guilt. Things could get worse if I can be more positive, and it will be my fault. Unfair responsibility. I have to be well so that others don't suffer. Loneliness, depriving ourselves of the understanding of others. So my suggestions when talking about anybody else than yourself or your own children. Use clinically accurate and specific terms to describe patients and the illnesses. He's undergoing chemotherapy and radiation to stop cancer growth, not he's a warrior battling cancer. Stop referring to cancer as a personal battle of the patients. Somebody's undergoing cancer treatment. Somebody died because of cancer. Mary's cured of cancer. 3, use language that encourages the patient to show real emotions, acknowledging the vulnerability of the patient. 4, avoid speeches that romanticize cancer. You are strong enough. Only in the darkness you will see the stars. You are an inspiration. And at last, avoid using the word cancer as a metaphor or synonym of destruction and or corruption. So I want to say that for parents and family members, the use of language may have a critical impact as well. We families may also feel overwhelmed by the word language used to talk to us. We also feel the burden of having to show the right attitude to fight cancer. And we put a burden on the patient's relatives as well. Does the family choose or want to inspire others? Were they given the choice? Most of the parents I've met, including myself 20 years ago, feel scared, useless, furious, and frustrated. But again, the social mandate demands us to be strong to fight the war. What happens if the child doesn't survive? Is he or she a loser? Are the parents loser? This is a quote from a mother told me. You feel like you're letting people down if you can manage to be always positive or if you have an emotional hard day. This is not helpful when trying to focus on getting through the day-to-day of cancer diagnosis and treatment schedule. I'm just trying to cope with each day at a time, hoping this ends soon. This is harder. This comes from a bereaved mother. My daughter did not let herself be defeated. She tried so hard. She never refused any procedure, even if painful. She kept smiling and hoping to be cured. She didn't lose the battle. Hearing that left me with a bitter feeling. Her death was not her defeat. This change of perspective has eased the pain of so many bereaved parents and has loosened the stress of so many patients and their families. Please acknowledge your feelings. Let us be sad, terrified, or angry. So, anyone with the experience of cancer, and I'm sure everybody here, knows well the kind of looks you get after the diagnosis. With this presentation, I hope that we have all reflected on the language we use when talking about cancer and consider that maybe the use of military terminology is making people more fearful and fatalistic about this curable disease. Maybe framing cancer in military terms may have a negative impact on how people think about cancer and cancer patients. Maybe when using the brave, fighter, warrior image, we are putting an awful lot of pressure on the patients diagnosed with cancer. Maybe patients feel a social mandate to be brave. Maybe the families are feeling the same. Maybe it would be easier if we use another type of terminology. So I want to end up with John Morris' quote. We need another kind of hero altogether. A hero now isn't someone who goes out and fights the sea. The hero now isn't someone who wields a sword. It's someone who puts down his sword and lets nature happen to him. So just to finish, I'm going to share a poem. I'm not brave. I'm not strong. I don't want to be a superhero. I don't want to be inspiring. Please don't expect me to be so. I never chose to be here. I would have never chosen this path. I would have chosen for my family to live an ordinary life. I would have chosen for my son to have a happy childhood, but I wasn't given the choice. Let me yell that I'm sad, angry, scared, exhausted, and overwhelmed. Don't call me or my son a brave warrior. Don't expect us to fight any battle. This is not our war. This is the scientists' war. They are the ones fighting, trying to defeat this disease. They will lose or win this battle, not us. We are the battleground. We will only cope with the effects of their war. I trust they will wear their best armors and weapons. I know they will. Please do all you can do to save our lives. Only you can do it. There's nothing we can do from this side. All I can do is to be by my son and try to cope with our feelings. And so I wanted to say thank you to Angus Olsen from Australia, also the father of a childhood cancer survivor. And thank you. My email is in the screen, so if somebody wants to reach me after the presentation, I will be happy to get in touch.
Thank you so much, Alejandra, for such an amazing presentation that has certainly gotten us all thinking. I suspect these are the words that we need and not a reflection of what the children need at all. My sincere apologies to everyone also for the technical difficulties at the start of the meeting. I am so happy to be here joining you now. So a very belated hello and welcome. This week is International Childhood Cancer Survivors Week, and it celebrates the lives of our children and it commemorates their courage and the support and love of their families. It is a time for raising awareness within our communities, as well as a time for child and adolescent cancer survivors and their families to reflect and grow in understanding of the issues and challenges that may unfold during the survivorship phase. As part of this week's initiatives, Childhood Cancer International and the International Society of Paediatric Oncology are holding 2 webinars. One is being held at a time most suitable for those living in European countries, and our webinar is to include everyone else. So with that, I would like to sincerely welcome every one of you to today's webinar. I know we have attendees from India to South America, back to Asia, over to the US, and of course, Australasia. So we are the ones truly hosting a global webinar that includes and welcomes everyone with all our lived experiences and different perspectives. And I think, as we've already seen, this is going to make for a really rich discussion today. So I'm very excited. I will be your host for the next hour or so. I am Jordana McClune. I am a senior postdoctoral fellow at the University of New South Wales in Sydney, Australia. I have been involved in childhood cancer survivorship research now for over 15 years, and I'm thrilled to be here with you today. A big thank you to Kate Johnson for the invitation and the last-minute stress I put on her trying to join the webinar, and for all her tireless work to help organise this event. Kate's probably already mentioned that she's kindly agreed to moderate all the questions and comments, so please send them through in the chat or the Q&A portal. We're going to save them up for the end. We'll let the speakers speak, and then we'll come back and we'll do all the questions at the end. But please feel free to keep them coming so you don't forget. We definitely want to hear from you. Kate, did we have a chance to play the video, the welcome from CCI or from SIOP? Or
Yes, we did. So we've done
wonderful.
that. And Alejandra generously introduced herself because I was typing at the same time. But we, if we could do a general introduction of everybody else now, that would be amazing.
Yeah, absolutely. So I'm so pleased to have the honour to introduce our next speaker, Dr. Dylan Graetz. I hope I'm pronouncing your surname correctly. She is going to give us a fabulous presentation on communication priorities and the impact of stigma. Dr. Dylan Graetz is a paediatric oncologist and assistant professor at St. Jude's Children's Research Hospital, where she directs the Culture and Communication program within the Department of Global Paediatric Medicine. Dr. Graetz conducts mixed methods research, which focuses on how cultural context impacts interactions between paediatric cancer patients and families and their healthcare teams. Through her work, Dr. Graetz aims to understand and enhance communication practices and patient-centred care of paediatric oncology patients in global settings, as well as interdisciplinary communication of healthcare teams. Her work spans the globe, including ongoing studies in the United States, Guatemala, Pakistan, Jordan, Zimbabwe, and the Philippines. Clinically, Dylan tries to treat children with solid tumours with a specific focus on renal cancers. What an incredible honour and opportunity it is to listen to you speak. So please take the floor. A huge welcome and thank you for joining us, Dylan.
Thank you all. Thank you, Jordana, for that sweet welcome, and welcome to you as well. And it's always a tough act to follow, Alejandra, so I will do my best, but thank you for that amazing presentation. I have actually seen it before and it still gave me chills and brought tears to my eyes and taught me new things. So I think I probably speak for everybody. You're just phenomenal and it's always a pleasure to speak with you. This is going to be a very different type of presentation, and as we've said, from a very different perspective. So again, I'm an oncologist and a researcher, and it's really just my privilege to treat children and their families, and work with all of you. So hopefully, let's see, can you see my screen?
Yep, perfect. You might want to put it, we can see your notes. Yeah, beautiful. And I'm also going to be the very snarky timekeeper, so I'll just give you a warning at 1 minute, okay?
Perfect.
Brilliant. Thank you.
All right. So I'm going to focus on patient-centered care and really communication and stigma as two aspects of patient-centered care. So this is a model of patient-centered care that we published in 2022. And I think it'll look familiar to all of you. It's based off of many models of patient-centered care, including one by the WHO, that are these series of concentric circles with the patient at the center. I think what's unique about our model is that we've put the clinician in the model as a mirror to that patient, surrounded by their own concentric circles, because we wanted to bring awareness to the fact that we clinicians are also surrounded by our teams, by our resources, and have our own cultural context, the culture of medicine that we bring to the interactions. And my work and the work of our team really focuses on these interactions because we believe that it's the interactions that have the biggest opportunity to impact care. And in impacting care, we are talking about quality of care, access to care, and outcomes such as treatment abandonment. And we know that communication is central to pediatric cancer care and a really central interaction. Most of the data on pediatric cancer communication comes from high-income countries and predominantly Western high-income countries, but it demonstrates that high-quality communication increases hope, trust, peace of mind, and sense of purpose for patients and families with cancer. We know that it enables decision-making and care for the child at home. And on the flip side, we've learned that poor communication contributes to regret, poor understanding, and emotional distress. However, pediatric cancer communication has been understudied in low and middle income countries and understudied in most cultural settings. We know that most clinicians around the world who take care of kids with cancer do not receive any communication training. And we don't know if the models and priorities identified in high-income Western settings apply everywhere. So we're learning a lot about the impact of culture and context on the interactions. And this is a model for patient-centered communication. Like I said, much of this comes from high-income countries. This model was published in the early 2000s in the US and actually was published first from work done with adult oncology. And it defined 6 functions of adult cancer communication. And those are here: exchanging information, enabling patient self-management, responding to emotions, making decisions, fostering healing relationships, and managing uncertainty, saying that all of these functions of communication impact health outcomes. And in 2020, this model was adapted for pediatric cancer, and 2 additional functions were added, which are providing validation and supporting hope. However, this work too was all done in the US. So we've been conducting mixed methods work in culturally distinct low and middle income countries to see if this model applies. We began this work in 2017 when we had the initial 6 functions, and then have continued it using the 8 functions. So our initial work was in Guatemala, and we've since moved to Pakistan and are just this week got IRB approval to conduct this research in the Philippines. And what we've seen in Guatemala and in Pakistan is that all of these functions are relevant. In Pakistan, we really saw trust, which had been previously looped into the building relationships function, pulled out as a separate function that was really central to the model. So here you see our revised model. We also learned through this deep qualitative work that families come to cancer therapy with pre-existing beliefs that are impacted by their diagnostic process. And we began to develop determinants at the level of the institution, clinician, patient, and family. Quantitatively, we found that communication priorities, so you can see this graph, this is from our Guatemala data, and in the teal you see what percentage of families surveyed prioritized each function, and you can see they're very high. And the blue is their described experiences of those functions. So each function was highly prioritized and not experienced to that same by the same amount of parents who prioritized it. We also saw that over 95% of families wanted all details about their child's illness, including chance of cure and late effects, but only 67% of parents said they got the information they thought was important without asking. And 74% told us they had questions they'd wanted to ask a clinician but did not. This work also highlighted specific populations at high risk for poor information exchange, including families of patients with solid tumors, as well as caregivers who were less likely to have their preferred role in decision-making. And in this case, specifically, that was mothers. In Pakistan, similarly, we found over 97% of families wanted all details about their child's illness. And we started to go more in depth about how and when they wanted this information. And this is where we saw high variability, with some families wanting a lot of information up front and others preferring that it be given to them over time. We also began to dive deeper into who they wanted present. And this varied a lot, both in terms of who they wanted from the clinical team to share the information and which family members they wanted to receive the information. Interestingly, we've really started to look at child involvement in these conversations. And 42% of parents actually said they didn't specifically want anyone to tell their child about the cancer diagnosis and treatment. Although 42% said they didn't want that, 70% of parents said nobody did, which means you have about 30% of parents who would have wanted help either explaining or having someone else explain the diagnosis to a pediatric patient with cancer, and it didn't happen. You see this number of families who got the information they wanted was a bit lower in Pakistan, only 38%, and 78% had questions they wanted to ask but didn't. Like I said, we're just about to begin similar work in the Philippines, and this deep work has allowed both for us to begin thinking about interventions at these institutions in these countries and present the data regionally, as well as allowed for comparative analysis. And it's been sort of the foundation for our global work, which is to establish quality indicators for patient-centered communication. Right now, there are no indicators for communication. And so we don't know whether when we make changes, it's an improvement or not. So the first step is really to establish these indicators. And we've conducted 65 interviews with very generous help from many folks here and CCI. And we've conducted these interviews with parents, with survivors, and with clinicians. And we are having a workshop in November, and I look forward to seeing some of you there to really present this qualitative data and start to define indicators that we can measure. So I know I'm probably running on time already, but I'm going to talk a little bit about our work on stigma, because like I said, we know culture impacts interactions, and stigma is the first way we've started to study cultural context. So stigma has been studied in a myriad of health conditions, but it's been understudied in pediatric oncology. I think all of us who are exposed to pediatric oncology, either as patients, as survivors, as parents, as clinicians, know that stigma exists, but it just hasn't been a specific focus of research. And part of that is that it had been thought that it's too culturally nuanced to be studied on a broad scale. So if you were going to study stigma in pediatric cancer, maybe you needed to study it in one disease, in one age population, or in one specific institution or country or region. But we decided to try to study it broadly. And so we looked at 3 different populations in Zimbabwe, Guatemala, and Jordan. And we looked at 2 different patient populations, osteosarcoma and retinoblastoma. We chose those diseases to start because of the disease-altering surgeries, the appearance-altering surgeries that are often necessary, being enucleation and amputation, but also because retinoblastoma, as many of you know, affects infants and allowed us to study stigma transference to parents, whereas osteosarcoma often affects adolescents and allowed us to explore the experience of stigma among adolescents. And what we found was that pediatric cancer stigma was really a shared experience, that the outgroup of being diagnosed with a pediatric cancer or having a family member, a child diagnosed with a childhood cancer, folks shared many more things about their experience than differences. There certainly were some unique things that only came up in 2 out of our 3 sites, or perhaps even 1. And so this Venn diagram tries to demonstrate that. But this really taught us that maybe we could study stigma, pediatric cancer stigma globally. And I just want to say we used a framework for this study, the Health Stigma and Discrimination Framework, that again has been used and designed for global populations, but had never been used in pediatric cancer. So we adapted this model for pediatric cancer and started to highlight mitigators and potential interventions. We also piloted 2 quantitative instruments to try to measure stigma. They required significant adaptation. They did detect really high levels of stigma, and so we think that it's worth pursuing. But because we had to adapt them so much, we really think we probably need unique tools for pediatric cancer stigma, and that's been our recent work. So we started with a literature review of all measures that study stigma in any health condition. We actually found over 900 measures, but less than 3% of those had been used with children at all, let alone childhood cancer. And then we've been, again, with folks from this group and other members of CCI involved in some concept mapping. And our goal, and we're almost there, is to develop 2 tools, which will pilot and simultaneously develop in 3 languages. So our qualitative work really taught us that the stigma experienced by patients and survivors is different than the associative stigma that's experienced by their caregivers. And we really feel like because caregivers experience their own stigma, it's going to be difficult for them to assess the stigma of their children as proxy. So we have 2 tools, one for the caregivers and one for patients through survivorship, 8 to 18-year-olds. And the 3 languages are in English, Spanish, and Arabic. And our patient level tool, which is, we have a preliminary version and we're about to start pilot testing it, actually has 6 domains. So there are 3 domains at the level of the individual: perceived stigma, internalized stigma, and a behavioral response to stigma. 1 at the level of the family, and 2 more at the level of the community, including individual discrimination experiences, and then systemic or organizational discrimination. So like I said, we're just about, we call this study Respect, Researching Stigma in Pediatric Cancer tool. And we're about to start piloting in the US, Guatemala, and Jordan. And then we hope that there will be interest in further translation and adaptation for as many global clinical settings as are interested in as many languages. Again, the idea is that these tools will be pragmatic and used at the bedside. And so if we're going to use them at the bedside, the next step, of course, is interventions to mitigate stigma, so that the tools could detect patients who are at risk of stigma and trigger interventions. And we expect the interventions to be quite different based on site. So many thanks. This is perfect. This is just a very small picture of a little group of us. There are many more people, but I thought that it was just like our patients and families are the core of what we do. It's really person-centered work, and it's the team and the joy that working with folks brings me. And so this felt better than a list of all of the many names, which I would inevitably miss one. But this is a team sport, and so I'm really grateful for everyone that I work with, and grateful to be here with all of you.
Wow, thank you, Dylan, so much. And what a pro, finished right on time. Oops, oh, there you go. Oh, gosh. Well done. Thank you so much. That's incredible work that you are doing globally on such an important issue. And I know just the amount of work that it takes for every iteration and every pilot testing and development and so forth. That's incredible. I'm sure we'll have lots of questions at the end as well for you. I would now like us to turn to introduce our next speaker, Mahati Chittem. And again, I apologize if I pronounced your name wrong. We're going to have a lovely presentation on experiences of stigma and the need for communication, perspectives from parents of children with cancer in India. So really keeping with today's theme of communication and stigma. Mahati is a professor of health and medical psychology in the Department of Liberal Arts at the Indian Institute of Technology in Hyderabad. Her core areas of work are in chronic disease management and cultural aspects of health behaviours. Within the space of chronic disease management, her major focus area is psycho-oncology, wherein she explores doctor-patient family communication, end-of-life issues, adherence, unmet and undermet needs, and the cultural connotations of concepts such as awareness, wellness, and survivorship. Thank you so much for joining us today, Mahati. We look forward to your presentation. And again, I'll keep time and give you a minute warning. Thank you.
Thank you for that introduction, Jordana. You pronounced my surname correctly, Chittem, and it's Hyderabad, not whatever the pronunciation was. I'm going to try and share my screen. So I have told Dylan this before, right? That in India with government institutes, you're not supposed to use Zoom. So I'm not as well versed with Zoom as I would be with other modes of communication. So I'm going to give this a go though. Should I share just my entire screen? And is that the easiest way to do this?
Yeah, that would be great.
Okay. Is this working?
It's coming. Yeah, perfect. Wonderful.
Okay, cool. Well, I can't see myself, but, so Jordana, if I'm running over time, which I think it's highly unlikely, do just unmute yourself and let me know. Right. So today I will be talking about one of our qualitative studies around retinoblastoma, but I'll talk you through it over the next few slides. I wanted to quickly introduce our research group. We do a lot of research within psycho-oncology, but also other diseases as well. So psychosocial diabetes, chronic kidney disease, pediatric diseases, but neurological as well as oncological, and women's health, specifically focusing on endocrinology. So these are our chronic diseases spaces. Alongside that, we do cultural antecedents of behavioral health and the psychosocial aspects of medtech. A lot of our medtech research is actually with pediatric oncology settings, where we are, for example, looking at how we can develop a 3D vein viewer and a venipuncture device so that when treatments are being administered, they're not so painful, especially for our pediatric cases. So I'm just going to help paint a little bit of a picture about childhood cancers in India from a more research point of view. I appreciate the fact that so many of the people within this group are not necessarily from India. So in terms of incidence, we have 50,000 new childhood cancer cases per year in India, which is quite high. It accounts for about 20% of all the pediatric cancers in the world. We see a range of the common types of cancers. And while I, again, understand that some of these cancers may not necessarily present themselves as a high disease burden in some countries, they do in India. And in terms of mortality rates, again, I'm sure you're aware that LMICs still have a greater incidence of mortality rates of pediatric cancers. India being one of the countries that is, unfortunately, one of the more front-runner countries, I'd say, for this. In terms of pediatric wards in India, again, you will see that we don't have so many dedicated pediatric wards, especially for oncocare in India. These numbers that I'm presenting over here, in terms of all of them are practically less than 50%, are pediatric wards in general. This is not about oncology wards. I can count on my hands the number of specialists we have in this in the onco space for pediatrics. In terms of the common barriers to care provision in India, and this is a very big issue that we encounter in the country, is we have these barriers, I would say, alongside about, say, 3 main areas. So initially, there is a lot of, once a person has identified the cancer and has reached tertiary level hospital, there tend to be a lot of financial toxicity, financial issues, and logistical issues regarding travel and accommodation. Now, what happens in India is that many people are unable to identify the symptoms of a pediatric cancer. And given the fact that we are currently trying to bolster our public health initiatives and our public health centers, what we call PHCs, it still ends up that a lot of patients, adult and pediatric, end up at the tertiary level hospital. That means they have to come all the way from wherever they are located to the tertiary level centers. And these used to be in the big cities of every state in India, but now we grade our cities as tier 1, tier 2 cities. And so tier 1 cities were where most of the funding and most of the tertiary level hospitals were located. And now there's been some more funding from the government to help strengthen the tier 2 cities. But still, a lot of our cases come from tier 3 and lower level cities. So we are still working on trying to enhance care provision at this point. So we do come across a lot of parents who have issues around, how do I travel to this tertiary level center? How do I look into accommodation? We have organizations like St. Jude's that does offer some accommodation, care, provision, but there are not so many beds available to these families. So there are only less than 10% of these families that get the care or the support that is required for them. So what this leads to is treatment abandonment. It's been a well-researched topic within pediatrics in India because treatment abandonment continues to be a very big issue that we encounter. So treatable cancers become untreatable. This is somewhat true for adult cancers, but very true for pediatrics. The next issue that we encounter are inadequate resources because there's lack of awareness that there's even a support need over here. So in a lot of our research with young kids, what we've seen is, say, neurological diseases, right? Speech difficulties can come up. And many times in our research, we've encountered families say, we don't even know that this could be an issue. Nobody's told us this could be an issue. And we absolutely don't know of anyone who can help us with this. And again, we don't have awareness this is an issue. So of course, then it becomes harder to help train individuals in that space. Language and literacy issues are something also that we encounter. Now, language is an area that we do a lot of research in, and I really appreciate the conversations we've had earlier on as well, because the way that we describe cancer really is different. We see that a lot of young parents will describe their child's cancer as fever, because that's one of our most immediate symptom that you can see in a child, right? And that the most persistent one. But the doctor will refer to the cancer by its appropriate terminology. And these can cause a lot of gaps between the parents and the physician. And so that could also create a lot of spaces. It creates opportunities, I would say, to help bridge that gap. And on a third level, what we see is that in terms of screening and stigma, these are interlinked in our country. We see that there are a lot of supportive care needs that remain unmet, and as well as information needs, which is what I'll be talking about as we go forward. Now that I've helped kind of paint a bit of a picture, I'll quickly get through the rest of the slides. So in terms of stigma and survivorship and research in India, it's very sparse. And what we've seen is that a lot of it is qualitative as well. The perceptions of childhood cancer tend to link it to God's wrath, which is 75% of the people in that qualitative study have referred to it as that. They think of it as an infection, something that was communicable. They look at environmental factors, and the child, there's this very strong belief that the child can never return to normal life ever again. And that can really perpetuate stigmatized notions about especially pediatric cancers. There's a strong hesitancy to receive treatment, which is linked to treatment abandonment. There's a fear of adverse effects, that the chemotherapy is not going to work out the right way, and I could lose my child in this experience. There are a lot of misperceptions, as the ones that I've spoken about in the previous bits. And interestingly, we've also come across many families talk about the lack of family support or social support and social isolation during the cancer journey, but also after. And what's interesting is that a lot of the sources of information, even for parents who are experiencing caregiving to their child with cancer, is that their main source of information still is online media, televisions and cinema being a very potent source of information, as well as social media. So it kind of really highlights the abject lack of access to information. Outcomes of stigma, especially post-treatment, has been studied by a couple of colleagues in India. What we've seen is that because of the stigma that parents experience and children experience during the journey, there are unaddressed emotional distress for young children especially. Many families report that they relocated to avoid the social stigma. So many, so there was one, I couldn't find the quote, but I remember reading it by one of my colleagues, Surendran and Chindu, where where the participant had said that I'm just a laborer. So a laborer is somebody who works, say, as a plumber. And I'm located in a small little village, and I can never go back there because now I have a kid who has cancer. And so this person relocated to a completely different state where the language was completely different as well. So that is the degree to which people are willing to, completely change their lives to avoid that social stigma. And many times children and families are left with feelings of inferiority and low self-esteem. So this is in spite of the fact that almost all the participants knew that cancer was curable and they knew the types of cancer that children can get. Now, in survivorship research, what we've seen among the 1 or 2 studies that did get published in India is that one of the major challenges for survivors is receiving information and continued support. There are late effects as well that, late barely ever have follow-ups, and help is rarely sought for. Rapport building and communication are something that groups have said is very important. Oh, shucks. Oh my God, I've spoken very slowly, clearly, but I'll get through this quickly. I'm sorry. So unmet information needs is something that we have explored in our study. We interviewed 40 parents of children with retinoblastoma. We chose retinoblastoma because it's a very curable disease. And we looked at their experiences both in terms of enucleation and chemotherapy. Many different, thematics came up from it, but the ones that I really want to talk about before I wrap up is that gender and stigma really came up as a very important area that we need to explore when a child, especially when a girl has cancer, retinoblastoma, anything that changes their appearance, it does bring up a lot of issues. There's a lack of information and on the appropriate center to get to, and there's a lot of loss of time because nobody wants to talk about it. There's the terminology. I talked about it earlier. When you use the right language, that can help. And the parents' role in causing this cancer, especially with retinoblastoma, because it can be passed on because of genetics within the family, right? So that, again, the parents also experience a lot of stigma associated to this type of cancer. So these are some of the findings that came up, and we are currently looking at this model to help address it so that we can, in a very lean way, help address universal, targeted, and very specific issues that parents who are providing care for their children can look at. I'm really sorry that I have not been able to talk about all the findings, but I'm hoping that I would be able to whenever any questions come up. And thank you for listening to our talk so far.
Absolutely. Thank you so much, Mahati. It's just the body of work that you have. I'm sure we could triple the length of your presentation. I'm so sorry we had to have a limit on today because it is so fascinating. There's so much there to talk about. Again, I'm sure there'll be lots of wonderful questions, and thank you for bringing your Indian perspective because it is very different. And so it's wonderful for us to all hear and learn and raise that awareness. Thank you.
Thank you.
And now we're going to, I'd love to introduce you to a survivor with lived experience. Again, I'm going to take a chance on your name. Chandan Kumar. Did I get close? And he's very kindly agreed to tell us his story. So rather than an introduction today, I'm going to let Chandan introduce himself as part of his story and give him the floor to tell us about what your lived experience has been. Thanks so much. And again, I'll just play the nasty timekeeper and give you a 1-minute call as well.
Yeah, sure. Thank you. Thank you, Jordana, for giving me this opportunity. And thank you, CCI. So my name is Chandan Kumar. I am an acute lymphoblastic leukemia survivor and one of the founding member of India's largest survivor group, Kids Can Connect. And it is like, and I have like the very, very bad experience with the stigma, and I'm going to talk about that only. And I'm also going to talk about that how you can communicate effectively to remove a stigma from the society. I'm going to talk about my experience and my wife's experience a little bit. So before that, I'm going to give you a brief overview about the childhood cancer incidence in India. And because Dr. Mahati has already given some of the introductions, so I'll not go into deep, but I'll introduce. So I have mentioned here like the childhood cancer incidence 76,000. So don't get confused with the 50,000 and 76,000. I'll give you the context that why I've taken the 76,000. So 76,000 childhood cancer in India every year. And I have taken the age group of 0 to 19. And the 50,000 number is, if you take a 0 to 14 of year of age group, then the incidence is 50,000. And surprisingly, 50% of these incidents are not even reaching to the cancer centers and dying somewhere in the primary healthcare center at home or anywhere, but they are not reaching to the cancer center. And one of the major reason the patients are not reaching the cancer center is because of stigma and the societal ignorance. Despite all of the effort, the survival rate in India is around 50 to 70%. But if you compare with the Western countries, then the survival rate is more than 90% in some cases, and in some cases like almost 100%. Right, but India is far, far away from that, and we are trying to get there by 2030. Yes, so stigma is according to me, stigma is a very, very major issue in India because it's often perceived like the life-threatening event, evoking feelings of uncertainty, fear, loss in individuals, irrespective of their prognosis. And these things are creating stigma into the patient, their family, and in the society. And this is why this leads to the hindrance to early diagnosis. In some cases, the patient and their family are leaving the treatment in between because they are afraid that their villagers or their community might get them outcasted, and they will not be accepted in their community. They might have to completely migrate from one city to another city for the treatment, and many reasons, right? And because of all this, the patient and their family gets emotional and psychological effect. They face a lot of psychological issue and everything. And because of this, because in some cases people migrate from one city to another city, one state to another state, and that's why they tend to lose their job and their primary source of income, and that's why they feel like they feel economic challenges in India. I'm going to share my experience. I originally, Dr. Mahati would know, I originally belongs from the Bihar, the Nalanda, Bihar, and I got cancer diagnosed in 2005, June 2005. It was 22nd of June. I came to Delhi from Bihar for the treatment, and it's like the 1200 kilometer away from my hometown. I got the first 6 months of active treatment, and then I went back to my village, and I was very good with the cricket. Right. So I was asking my father that when I'll go back to home and I want to play cricket, I'll when I'll start playing cricket, I'll get well. So don't worry about that. But when I went back to my village after 6 months with no hair and the mask and everything, my experience was very traumatic. I was 12 year at that time. I was 12 year old, and when I went there, all my friends were not ready to talk to me. They were not ready to play with me. My community was not ready to accept me. They were like avoiding me and my family with the fear that they might get also affected with the cancer, because there is a very less education and awareness that the childhood cancer is not the communicable disease. But in my village, it was like they might get affected because I have a cancer. If they will play with me, they will talk to me, they will also get affected by cancer. So this was my experience. Then I told my father that I don't want to live here in this village. And then my whole family migrated to Delhi. In 2006, then I realized that what should I do? Should I accept this or should I fight with this? Then I decided that no, I should not accept this. I should not be defeated by all these things. I should fight. I should fight back, not only for myself, but for those who is already fighting with the cancer and who is already going through this journey, and for those who will go through this journey in the future. And that's when I decided to do something. I had no idea what to do. I had no experience to set up anything or do anything. I had to miss my school for 3 years because I migrated from one city to another city, and I had to left the school. All my friends, everything in my village came to Delhi. And then I decided to do something. Right. Then I decided to do something. And at that when in 2006, I started a community, which is like currently, which has more than 2,500 survivors right now. It's called Kids Can Connect. We met a few patients in the hospital and in other places who had the similar kind of experience. One of the patient at that time was my current wife, Ritu Balla. She had denied admission in school, and she had the similar kind of experience that her principal has denied this admission in school because the principal had thought that if she will sit in the classroom, there are another 50 children in that classroom, and then all the 50 children will be at risk because she is getting through the cancer treatment, and that might affect the other 50 children. And that's why she denied the admission in school. With the 6 other people, we have like decided to form a group, started meeting together. The community has started growing up because many people are joining our group, and they were sharing that they had also faced some similar kind of stigma, and they had similar kind of experiences. After a few months of the meeting and thought, and we decided that we should now communicate, because now our group has like enough people. Now we should communicate. We should go back to the society and we should communicate that the childhood cancer is curable and it's not a communicable disease. So then we thought that how we should communicate. So we had started doing street plays, which is called Nukkad Natak in India, street plays. And then we started writing the street plays based on our experiences. Like if the Ritubal denied this admission in school, so we had taken that story, we converted that into the street play, and then we started performing street plays at different public places and different areas. Until now, we have already performed on more than 1,000 times across India. So this was the one way to communicate that the childhood cancer is not the childhood cancer is curable and it's not a communicable disease. So so that people get normalized with it and they accept that the childhood cancer is curable and it's not the communicable disease, right? After doing this all this for 3-4 years, and in 2000 from 2008 and 10, we had started doing a larger campaign to influence the government advocacy, government policy, because right now in India there is no separate policy for childhood cancer. It's a part of the larger policy, NPCDCS policy, but there is no separate policy. But the childhood cancer has the more cure rate than the adult and everything. So we are trying to advocate the government to make a separate childhood cancer policy for India. And that's when we had started the larger campaign, government advocacy campaign, and it was a signature campaign. So we had started collecting signature for 400,000 signatures, so that we can ask the government to make childhood cancer child health priority in India. And why 400,000? Because if you consider the global incidence every year, it's the 400,000, and that's why we have decided that we should also collect the signature at that amount, 400,000. And
1 minute.
Yeah. After 5 years of long struggle, we were able to achieve. Now we are going back to the government to with the draft policy. We had also set up Indian Childhood Cancer Initiative with the help of St. Jude in India, and I am one of the co-chair of the one task force, and we are making a draft policy so that we can go back to the government and ask them to modify their policies. So this is how you can communicate, and you can choose any medium of your communication. You can communicate through the social media to eradicate the stigma. You can communicate through the TV, radio, and everything. You can choose your medium of communication to talk to the society, talk to the people in your community. But it is very important to communicate about something, and no one else is going to communicate. If you are a survivor, if you are a patient, if you are a family who are going through this journey, you have to take a step, you have to communicate, and then only we will able to eradicate the stigma from the society. Thank you.
Thank you so much. I'm so sorry to hear about your very difficult experience yourself in your childhood, but also a huge congratulations to all the work that you have done since, and your incredible way of bringing childhood cancer patients and survivors together. I'm sure that makes a big difference in so many lives. And then finally, that's all of our formal presentations for the morning. I would also love to introduce you to another childhood cancer survivor that we've had join us today. And I'm going to introduce you to Winnie Fu, tell you a little bit about her. And then Winnie is not going to give a formal presentation, but we'd love to ask her for her thoughts on and whether any of the talks today have resonated with her, to bring together and wrap up our talks, and then we'll open for questions. So Winnie was diagnosed with, I am a severe timekeeper even on myself. Winnie was diagnosed with MDS, transformed AML, at 17, and she has been in remission for 8 years now, thanks to the stem cell transplantation she received from an altruistic stranger, along with SCCS's financial aid. From then on, Winnie promised to always do her best in advocating for individuals living with cancer. And along the way, she has learned the importance of cancer patient and survivor-centered care, which further inspired her pursuing of tertiary studies in psychology. And she's about to kickstart her master's degree now in psychology. Congratulations, Winnie. That's absolutely amazing. And so I'm just going to throw to you now to see if you'd like to make any comments or insights or anything that resonated with you today from today's speeches.
Thank you so much, Dr. Georgiana. First of all, I just want to thank Kate for inviting me to this webinar, and also thank you to the amazing presenters, Mahati, Dylan, Alejandra, and Chandan. So yeah, I mean, it's, as usual, a lot of information, but definitely, I feel like the part about the language from the language presentation from Alejandra is really, really impactful because for me, I feel like you know, I was diagnosed at 17, so I was at the age where I understand metaphors and everything. So, but you know, sometimes I would, you know, when I tell my story to other people, people who haven't heard what happened, they would just say, "Oh, you're so brave." But I did not comment anything. I wouldn't usually comment, but in my head, I'm thinking, you know, this is just a thing that happened to me. Like, I did not choose to, you know, have cancer happen to me. So like, I feel like whatever that is thrown at me, I'm just going through it, like how you go through every other life's challenges. So that is one thing. And definitely another thing is, you know, talking about stigma. For me, I guess in my country per se, we didn't have that much of a stigma, or I would say like very upfront kind of discrimination happening. The stigma mainly is just, you know, my personal one. Like I remember at some point when I just completed my treatment, there's this really huge sense and heavy sense of loneliness that I felt because, you know, I had to repeat my studies for like a year, and then all of my friends, they have gone, you know, moved on with their lives, and I felt like, oh, I was, you know, left behind, and my future plans are not as what I had planned or mapped out pre-cancer. So it's yeah, it's this sort of like feeling that I get. And another thing is because right now I'm working in corporate, I'm working as a headhunter. And I only started working in corporate about 2 years ago. And I think I've heard from a lot of places, like, you know, in corporate, you should be careful, you shouldn't be friends with the colleagues, or not to be too close with other people, not to share too much of your personal life. But at the same time, I feel like, as you know, as someone who has been through cancer, recent cancer treatment, I felt like it is also important to share to people, to help them gain more awareness and things like that. But of course, I was trying to be careful at the same time. So fortunately, you know, I was able to share about my journey with my boss, and he's actually really, really understanding. He did not say anything like, "Oh, you're so brave," you know, like, or "Are you cured?" or things like that. He just say, "Oh, okay, I didn't know that. That's great." And then he asked a lot of questions about the cancer awareness campaign that I was involved in, about the SCCS, which is Sarawak Children's Cancer Society, the organization that I also volunteered with, you know, helping out with child cancer awareness campaigns and etc. And he's really, really interested, and you know, perhaps someday he might be actively involved in CSR for you know, for the organization. So I think of course you know, it's definitely up to each survivors to evaluate the situation, and whether or not they want to share, it's definitely up to them. Like they have the right to not share, and they have the right to want to share if they want to. And it's also something that we talked about in our just recent CCI in Japan. We had a survivors program thing for a day where we you know, we interacted with survivors from all over the world. And I've also connected with Sitara Khan from Can Kids. She's really, really amazing. She also gave an amazing presentation in CCI, and she also informed me that, you know, in India, back then when she was, you know, diagnosed, she had to undergo a hysterectomy, and then her parents at some point were in denial, because I think, you know, being a woman and being able to give birth is something that is, you know, really, really big, and having that taken away felt like, to her parents, it felt like it's, you know, taking away part of her identity. And we also talk about language and you know, connotations of certain languages as well. And I think we all have different answers. Of course, there's no right or wrong answers. I think one of the questions that we got is, would you describe that, you know, your cancer journey is how you define yourself today? Some of them say yes, some of them say partially yes, some of them say no, you know, because it is just something that they have to experience, like every other illnesses or any challenges that's being thrown to them at life. And some of them say yes, because it is, a great opportunity for them to reflect and to overcome the greatest challenges that they've ever been through. But I think all in all, being able to understand every cancer survivor's experiences and thought, it's great because again, there's no right or wrong answers. It's just how they all feel empowered by their own way of thoughts of how they perceive the world as well. So yeah, it has been really interesting. And I also understand that the age in which you get diagnosed with cancer, it also impacts on how you view everything as well. Like for me, I was diagnosed at 17. At least I'm able to, like I think Alejandra mentioned using the Piaget developmental stage. I think that really helped. Like at least there is like a logical thinking included. For some who was diagnosed when they were really young, they don't remember anything, but they are also interested, in helping out. There are some cancer survivors who were diagnosed really young and they don't remember anything, so they don't feel like it's relevant for them to be involved actively in this sort of awareness campaigns or volunteering or helping out and things like that. And I think it's really, really important as well, because another thing that we talked about is being able to understand your right to know your own medical history, especially for child cancer survivors who are diagnosed really young and they don't remember. And in some cases, their parents do not want to tell them what happened. So they, and when they're at the age where, the late effect comes in, they may have issues like fertility issues or other health issues, and they wouldn't really understand, why this is happening to me. So we were also like being empowered to take control of our health history. And, we have the right to ask our pediatricians, our doctors, the questions that we want answers to. So yep, that's just some of the things I hope to share as well.
That's such great insights, Winnie. Thank you so much. And I think you're quite right in saying there's no right or wrong answer, but it's all about empowering the childhood cancer survivor and that great communication that's really going to set them up to be empowered so that they can know their own health and know what questions and how to seek help should they need it. It's been an incredible discussion this morning. I'm going to throw to Kate now to see if she has just a couple of questions maybe we can have time to squeeze in. Are there any?
Anything, not in the Q&A. So if anyone has any questions now, put them in the chat. But actually, I have a question. Well, not so much a question, but just something, because I think what you just said, Winnie, is so interesting particularly about the age at which you're diagnosed, because I really think that makes such a massive difference. And, we talk about this quite a bit within CCI that, my David, for example, was 3 when he was diagnosed. And so he really doesn't even identify as a survivor because it's something that we've told him. It's not something he remembers. And so, but I also think it's really interesting if we link that back to what Dylan was talking about in her talk about that, as parents, if we're looking at kind of, did you call it family-centered care or communication? Did you call it family? Anyway, when you first said that, just can't remember the term that you used about the fact that, we're really...
Associative stigma?
No, just in
we talked about family-centered care.
Yeah, family-centered care. And that, that most parents say, we want all this information, like we want everything. We want all the information and, and yes, there was a bit of variability in terms of when you want that information, but we basically want all the information. If you then fast forward and you look at, for example, like a kid like David, who knew nothing at the time about what was going on. So all that information was coming through me, that now as a 15, just about to turn 16-year-old, and when he becomes an adult, I think that there's a gap in terms of like, how does he then get that information for him to then be able to take into his adulthood? Now, I mean, in Australia, we're really lucky. We have quite a well-developed sort of late effects clinic and that sort of thing, and they are trying to promote that. But I really think that this is going to be a bigger and bigger issue as we go on, because survivorship actually, I went to they talked about survivorship, but in adults. And, you know, the amount of money and effort and time that is spent talking about survivorship in adult cancers, when I look at our kids who, for some of them, were diagnosed at, you know, 2, 3, 4, they're going to experience these effects, you know, for the rest of their lives. And, you know, we really need to be kind of focusing in on that. Anyway, it was really fascinating, Winnie. I think your perspective and your insight is so interesting. And then to link it back to kind of the actual sort of research and, you know, across the world. So I really appreciate your thoughts, because it's really, really interesting.
I think Alejandra has a thought on that. Do you have something to follow up with?
Yeah, I just want to say that I want to say thank you, Winnie, for your insights and your perspectives. And when you were talking about, I just make some notes. You talked that after you finished treatment, that you felt like loneliness, and you mentioned that everybody went on with their lives, and that you were like stuck there, and your friends went on, and you were, and that's something that actually Kate and I have been talking a lot, and we're working, and because I think something that we really need to acknowledge is that survivors and the families of survivors, we also need room to grieve. I mean, there's a lot of, and usually, again, as I was telling in my presentation, is something about expectations, right? You finish treatment. In many countries, you ring the bell, and then the social mandate of the expectations of people are you to be in the celebration mood, are you to be like throwing a party and like, you know, having like this music, dancing, because you finished treatment. It's like a, you know, a landmark or something. You just you go there. But actually, what I'm talking about my experience and the hundreds of families I work with now. Actually, when you finish treatment, I think the society and all of us needs to acknowledge and recognize and give room for the survivors and their families to actually grieve. Because actually, we're going to have a presentation at the SIOP. Kate and I are working on that, calling that grief is not just about death. Also, Dylan, Dr. McNeil is going to be in the panel as well. And we're very excited to create awareness and to think and discuss about how those of us who are lucky enough to be in the survivors group, we lost a whole year or maybe more time. You were, or the parents see you in a hospital room instead of in the park playing with other kids. Your as parents, the professional life or whatever, or you maybe sometimes your marriage or your friends, and your life was stopped, and for a whole year you literally lived in a hospital, right? So even for survivors, you see your body changed. You know that you will have side effects eventually. Some of them will be a long term. So there's a lot to grieve about. And of course, I don't want to even compare the grief of a family whose child lost this and dies. But I think that it's important to consider that survivors also need room to grieve. And when you were talking about your feelings after finishing treatment, I really it really resonated with me, and so I want to say thank you. And even though we live in so different parts of the world, and our culture are probably very different, both of us felt that expectations or that feeling of having to grieve, even though we have or our children have survived.
And we have more comments coming in from the chat also about this and around stigma. So thank you to Sarah. Interesting to see the experiences and stigma from Brunei. One parent that she's worked with before voiced that she didn't want the public to know the child had cancer because then she might lose her chance of getting a scholarship for education or chances of marriage later in life. So from around the world, thank you for joining us, and all these universal experiences of stigma that exist. And we have to do so much more to continue to raise awareness. I have one question, if we have just a small amount of time. How much do you think stigma is linked to mortality and morbidity, and that in certain countries where cancer mortality and morbidity rates are higher, do you think the stigma increases, or do you think it is its own phenomenon and linked more to maybe the country's spiritual beliefs or awareness around non-communicable diseases and so forth? Anyone want to take a shot at that one?
Okay, I'll try.
I'm happy to.
Then
Okay. Mahati.
Go for it, Dylan. No, go for it.
Okay. Oh, we're too polite.
Sorry.
Mahati, you go first and then we'll follow up with Dylan.
Okay. I think it's a bit of both, and it's such a complex concept to understand. I do think that both, it's like a chicken or egg. The stigma does beget poor outcomes in terms of mortality, but also poor mortality begets increased, notions around what this means. But in the work that we've done, we've seen that it's definitely important. I mean, stigma does have a role to play in terms of the mortality rates in India, treatment abandonment, and, all the, even, it's not necessarily that, cancer is equal to death. It's also that cancer is equal to a very expensive disease in India. So there's also that aspect that comes into play. So I think, as I started off by saying, stigma, I think we tend to think of stigma only in these ideas of, oh, it's a misperception, or we're thinking about fatality and things like that. It also has these other more social aspects that impact it. So I do think it's connected to mortality, at least in low-income countries.
But that bit of a vicious cycle. Dylan, what are your thoughts on that?
Yeah, it's something I spend a lot of time thinking about. I mean, I think my perspective is one in which I'm really trying to break down these concepts so that we can study them, so that we can draw these connections, so that we can get more specific with our interventions and start really making a difference. I think, again, I agree with everything that Mahati said and everything that everyone said, which is that stigma is really interlinked with a lot of different aspects, both of culture and of care. And we've been really trying to be clear in our definitions of stigma. And as those here who have worked with me know, it's been, like I said, right now we have these domains, and 3 of them are personal, right? So this internalized stigma, this perceived stigma, the behavioral responses, and then we get at some of the discrimination, both that can be organizational or systemic, and we see that at a policy level, right? It's very different around the world, whether childhood cancer is included, and Chandan got to this a little bit, is included if there's a national cancer control plan, does it include childhood cancer? If you have protections with people for disabilities, is cancer on there? Is childhood cancer on there? How does that impact stigma? So I think it is very layered. There's stigma at the systems or organization level. There's stigma of the family, within the family. There's stigma at an individual level. Much of it can be influenced by misperceptions, by culture, by mortality rates, but that's also very cyclic. And I think even things like, when we've been trying to assess stigma and we talk about items that have to do with things like avoidance, we really are trying to be careful, because is that avoidance happening because of concern for contagion, which, not that cancer is contagious, but if you are a patient with cancer, you may be concerned about contagion and being around a lot of people. So does that isolation come from the fact that you're worried about getting sick, or does it come from the fact that there's a different type of stigma? And so I think right now, this is where I say stigma just needs a lot more research, because I think it's something we all can talk about and have experienced, but until we start to be able to have these models and draw these paths, it's going to be very hard to prove what I believe, which is that it does impact mortality, that it does impact treatment abandonment. And I think that's what people are always looking for from me right now, is like, can you show that your work on communication impacts morbidity and mortality? And like, no, I can't yet, because those are too distal. Like, there's too many other things. And so I have to be able to draw all these. And that's where I think if we can show that communication can change stigma, and that stigma is related to abandonment, we're starting to make these links. But I think back to maybe Alejandra's very first presentation, with everything, we have to be really conscious of our language, and that when we're talking about stigma, we're specific with what piece of stigma we're talking about and how it's being linked, and in what community or culture or individual.
Wow, so much great work already and so much work still needing to be done. That's phenomenal. Thank you so much to everyone for the wealth of information that you've brought and the thoughts that you've inspired. I think we are all going to walk away mulling over this for the rest of the day. Kate, if there's no more questions in the chat, I think this just comes down to thanking yourself for organising this event. You put so much hard work into it, and I know that everyone online, thank you so much for joining us literally from around the world today. It's a wonderful thing. And thank you so much to our presenters who did such a beautiful job, and work that they continue to do offline, and the dedication you have to this. And thank you to our survivors also for sharing their very personal stories. Everyone, please enjoy your weekend, and thank you again. We hope to see you next year. Thanks so much.
Bye-bye.
Yes,
Bye.
thanks everyone.
Thank you.
Bye-bye.